Bladder cancer presents usually with painless macroscopic hematuria. In other words, people pee blood without any pain. Now, with kidney stones, for example, bleeding in the urine is possible, but it's usually associated with a lot of pain. So the hallmark of bladder cancer is painless bleeding when a person passes urine. This is a symptom that must never be ignored, even if it happens only once and then stops. In urology, we say that blood in the urine is consistent with kidney or bladder cancer until proved otherwise. Therefore, anybody who sees blood in their urine needs to see a urology specialist and be thoroughly evaluated for the possibility of either kidney or bladder cancer. If a person has visible blood in their urine, they will have a CAT scan to check their kidneys. They will give 3 samples of urine to check for cancer cells in the urine. This is called urinary cytology. And then the urological surgeon will look inside the bladder. This technique is called cystoscopy. Under a general anaesthetic, a telescope with a video camera is passed into the bladder and the internal lining of the bladder is inspected. If there is a bladder cancer there, it's readily evident, and the urologist will then move on and resect that bladder cancer, gather the specimen and send it for pathological analysis. This will help to determine whether it is a low-grade or a high-grade bladder cancer, and that information then informs management. The majority of bladder cancers are low-grade and superficial, and therefore they are not life-threatening. Therefore, the management of low-grade bladder cancers is to have regular cystoscopic or telescopic inspections of the bladder. That might be 3, 6 or 12 monthly, depending on the degree of assessed risk and the degree to which they recur. Now, if they keep recurring, and particularly if they're of a higher grade, we use a therapy called BCG. This is an immune therapy that's administered into the bladder every 6 months, and it's been shown to significantly decrease the risk of early high-grade bladder cancer becoming life-threatening. Now, the management of high-grade bladder cancer that has invaded into the muscle of the bladder wall does need to be quite radical. There are 2 approaches. One is radiation therapy and the other is surgery. Usually, surgery is the preferred option. That involves removing the bladder, and in most cases, if the disease has been caught early, that is curable. The lymph nodes are also removed and assessed. Sometimes men and women who have radical cystectomy surgery may require chemotherapy post-operatively. Once the bladder's been removed, we then have to decide with respect to urinary diversion. In other words, the bladder's gone, so what do we do with the urine? The commonest means of managing that problem is to take a small piece of small bowel, join the ureter tubes from the kidney to that isolated limb of small bowel, and bring it out on the abdomen as a stoma. And that's similar to what happens with some types of rectal cancer. Patients have a colostomy. In the urological sense, it's called a urostomy. And that's quite easy to manage, and there are specialist nurses who support and educate men and women with the management of their stoma. In younger patients who are highly motivated, we may reconstruct the bladder. This is called neo-bladder reconstruction. We take a part of the bowel, we fashion it into a spherical shape, we join the ureters into that spherical shape and then join that back onto the urethra. And that's called neo-bladder reconstruction. The advantage of that is that there's no stoma. There are disadvantages though. There are metabolic, biochemical disadvantages, and some patients do need to self-catheterise 4 times a day for the rest of their lives. So it's very important that the urologist talks in detail to the patient, understands their particular wants and needs, and makes an assessment with respect to how well they'll cope with the different options. And in this way of two-way interchange, we find the solution that best suits the individual patient. Low-grade bladder cancer is certainly curable if it's kept under close surveillance. High-grade bladder cancer, if it's picked up early and treated aggressively, is curable. However, bladder cancer can be highly aggressive, and despite radical surgery, chemotherapy, radiation therapy, it may not be curable for all people. The pathologist makes a very careful assessment of the tissue that comes out of the bladder. They look at 2 things. They look at the type of cells, and that's how they categorise the cancer as high grade or low grade, and they then look to see whether it's superficial or invasive. Superficial means it's just sitting on the surface of the bladder, whereas invasive means it's burrowing into the layers, particularly the muscular layers of the bladder. So the best possibility is low-grade, non-invasive. The more dangerous possibility is high-grade, muscle-invasive. The pathologist is a very important part of the team in making these determinations. Bladder cancer is detected essentially by cystoscopy, by the insertion of a telescope into the bladder, and it is then to the experienced eye readily diagnosable.